Mulțumim pentru invitație, profesor Tinica, stimați colegi. Dacă nu vorbesc românește bine, trebuie să fac prezentare în limba engleză. Mă scuzați. So my topic of my presentation is new trends in aortic and mitral valve repair. And we do this kind of operation since about 20 years in our center in Novarra, Italy. I will start talking about the aortic valve surgery, new trends in this disease, as from 1990s, many centers, many surgeons started to repair those valves, taking into account that before the years 90, most of aortic valve operations were replacement only. Most of these were replacement aortic valve. And so the trend since the 90s was going towards the repair and going from full sternotomy to mini sternotomy. This for different reasons. You know very well that the valving sparing procedure first accomplished by Magdi Jakub, then by Dr. David, because the valve preservation gives different advantages, that is better quality of life, avoiding anticoagulation, completion of growth in children, possibility of pregnancy in women, preservation of ventricular function, and theoretically no reaction and no intrinsic gradient. But of course there are some limits and limitation of this operation, mostly regarding to redo operation, but this operation needs a learning curve and a specific training for surgeon and cardiologist. So we see, and we know that the aortic root is a complex system, and this Italian guy, this genius of Leonardo da Vinci, already studied the function of the sinus of Valsalva, and his conclusion is that the function indicates the structure. So we as a surgeon, we need a lot of experience, but he say nothing in nature is without reason, understand the reason, and you don't need experience, while for surgeon we need it. So the concept, I skip a little bit the hemodynamic function of the sinus of Valsalva, because of course there is time limitation, but our experience in this field of aortic valve repair started 20 years ago, and the classification I was told by Dr. Cherin is taken by the mitral classification of incompetence and insufficiency. There is type 1 with the normal aortic leaflet, type 2 prolapsing of one or more cusps, and type 3 restricted or retraction of one or more cusps. And so type 1, we have normal cusp for dilatation of the sinotubular junction, and in this case, we can restore the valve competence by replacing only the ascending aorta, reducing the sinotubular junction size, and it's quite easy operation. But the same type 1 we have in Marfan disease, and in those cases, we have dilatation, also the sinus of the Valsalva, and we need more complex operation like David or Jakub, and we talk about later. Type 2 is a prolapse of the cusps with disease of the commissures, and the cusp may be prolapsing for different reasons. One is dissection, but most frequent is a bicuspid valve, or even late referral for aneurysm of the ascending aorta. Type 3 is more difficult and less feasible. The repair are usually rheumatic patients. So the importance of echo is already be stressed by Dr. Cherin. Of course, we need a good echo in preoperative and also intraoperatively, because we need to go to exactly to know what is the level of cusp coaptation, the age of coaptation, and which is the reason and the direction of the jet. I don't go into details, but only to show some cases from our experience that only 10 years ago, when we have treated by replacement, now we routinely treat as aortic valve repair. This is a bicuspid aortic valve, for example, you see up on the left, with the important cusp prolapse. There is the common cusp that is more prolapsed than the other, and the coaptation is, there's a lack of coaptation with important incompetence, and this is also demonstrated by 3D echo. In this case, of course, the surgeon had to tailor the operation different from patient to patient. In this case, we did the triangular section of the plastic cusp and the suture and resuspension with the 6 or 7 Aortic on the free edge to restore the coaptation. The tube stay coaptation should be at least 6 millimeters and should stay above the aortic valve, the aortic annulus. And of course, you see the opening here is elliptical, this typical aspect, you know, for opening of the aortic, bicuspid aortic valve. And in the same way, we treat also other disease, more disease like this one, in which you see up on the left that there is a flail common leaflet, type 1, but it is a flail leaflet, sorry, type 2 of aortic incompetence, but the leaflet, you see the common leaflet completely invert its position into the ventricle, and this is quite more difficult to repair, depends about the tissue that we have to repair the valve. And of course, there is important, severe aortic regurgitation. Flushing leaflet is the common leaflets. You see it down in the down image. And for this kind of operation, we need to do resection of the redundant tissue and to do a suture of the prolapsing leaflet. And in some cases, if there is not enough tissue, we put also a pericardial patch for patch extension. And it's not an easy operation, it's a challenging operation, but anyway, it's extremely important to repair also this valve. And you can see here, despite the flailing leaflet now, we have, after the operation, a good coaptation and no aortic regurgitation, also with good opening. And also, of course, we control also the patient pre-discharge, and the results should be optimal. We not accept suboptimal result, of course. Otherwise, we have to reoperate those patients. Other case, this is a bicuspid aortic valve. You see down on the left that there is a lack of coaptation. There is not enough tissue to coapt those valves, so the leaflet do not touch one the other. And again, a bicuspid valve with the central eject. And also, in this case, like this case, we do aortic valve repair. In this case, right resection and no suture, because there was not calcification on the raphe or fibrotic, and so commissural repair. And we create, like you can see here, a tricuspid valve, because the anatomy was favorable. And this is the operating picture, where you see here we created tricuspid valve because we have a good raphe not calcified, and so the condition, the tissue was quite nice, so we could recreate a tricuspid valve, competent tricuspid valve. Again, on bicuspid, every valve is different from the other, and the surgeon, you see there is central lack of coaptation, and there is retraction of the free edge here with important regurgitation, and in this case it's quite more difficult because there is not enough tissue. In this situation, we prefer to do a cuspid reconstruction extension with the autologous pericardial autologous pericardium, so the extension could create enough tissue to have a coaptation, as you can see up on the right. And down here, and here. Of course, we want to have also a good result pre-discharge to check the result. So this only to say that now, since a few years, more and more aortic valve, because with aortic valve are not replaced, but are repaired thanks to the cooperation with our cardiologist in the operating room with the transesophageal echo, we can understand the anatomy. Again, this is a malformed patient with quite a good coaptation with dilatation of sinus of Valsalva. In this patient, this is a tricuspid, of course, the tricuspid aortic valve. You see very well here and here. Dilatation of sinus of Valsalva and ascending aorta. In this case, we prefer to do the David operation. We started in '96 to perform the Jakub operation, but then after 2 years, we switched to David operation for any malformation, any dilatation of the aortic root, because for us is more stable, gives more stable results. And here, I think you have the control. Again, bicuspid, we have also the condition of bicuspid aortic valve with aneurysm of ascending aorta. This is the case of another patient in which the David operation is a little bit more complex because there is not a symmetrical valve to reimplant in the tube. But if the leaflets are not calcified, if the leaflets are a thin leaflet, we prefer to do, and we choose to do repair also in bicuspid aortic valve with dilatation centers of Valsalva, performing a David operation, like in this case, and you see here very good coaptation because we have redundant tissue to co-opt. This is our result in David operation in the last 18 years. 136 patients operated with 96% normal aortic regurgitation, no patient with anticoagulation, and almost patients are in near class 1. Again, this is a similar case, so I skip because constraint of times. Of course, there are other techniques that we use for cusp in type 3. But in those cases, if the leaflets are thickened, we prefer to replace the valve and not to keep the valve disease for the patient. We have performed also 65 isolated aortic valve repair and with no mortality. And the overall experience, you see in the Jacob David ascending aorta and aortic valve isolated repair bicuspid repair gives up to more than 600 aortic valve repair in combined procedure. And this the follow-up, echo follow-up is very satisfactory at the mean follow-up of 6 years. What about the mitral valve? So, new trends of mitral valve is first of all going towards 100% repair in degenerative disease, of course, and if it's possible, also have 100% of repair in minimal invasive technique. And wire preserved mitral valve with complex disease, we know very well, but we have to repeat that the mortality rate is much lower in repair than compared to replacement. And also the event-free survival is much better if we repair those valves. Despite this very strong data, repair rate in Europe still remain about 62% and also in the States. But in dedicated center, the repair rate goes up to 95%. So the standard technique we learned from Professor Carpentier in the 80s was for posterior leaflet flail was to do quadrangular resection and sliding and so on. We use more rarely this technique, the tendency to preserve more valves. So this experience before 2009, more than 1,000 operations on mitral valve repair that we presented also in European and American Congress. This is not very important. But the new trends is toward more respect than resect. That means to try to perform this kind of procedure in which we resect less posterior leaflet to keep mobility of the posterior leaflet. With the huge resection, we have a fixed posterior leaflet. In our experience, personal experience, we prefer the new trends is to preserve more leaflet, and to have a mobility of course of the anterior, but mobility also the posterior. This is the idea repair with good coaptation and mobility of both leaflets. This is the trend we use and also other centers all over Europe. But the way from sternotomy to thoracotomy is not easy way. We started with Da Vinci in 2001, then we went also to Van Hermen. But we didn't like to use the Harpur system was too complex and in our idea. And so since 2009, we start routinely to perform mini thoracotomy for mitral valve repair. And we present in Mitral Conclave how to reduce the complication rate in the learning curve of mitral repair through mini thoracotomy, sorry. Because we use a simplified technique. Simplified means a single endotracheal tube, single venous cannulation, and we start with, of course, a mini thoracotomy in the third intercostal space and not in the fourth. And of course, we have an endoscopic setup in the operating room, and the cardiologist following us in the transesophageal echo, of course, to assess exactly the valve pathology. And the most important thing is that this surgery allows the same operation through this incision that is not only small incision, but is also really less invasive because you not cut the bone like in sternotomy. And as I told, the real interest is that we use we don't do incision on the groin, but only percutaneous vein cannulation, single vein cannulation in all the patient, even in patient with the tricuspid disease. We have we use a double, as you can see, double drainage cannula in superior vena cava, inferior vena cava by single cannula. That is easier operation. Single endotracheal tube and only skin incision that is in the third intercostal space. Direct aortic cannulation in ascending aorta, and also direct aortic cross clamping. So we try to reproduce the same operation that we did from sternotomy. That means direct anterograde perfusion, anterior cardioplegia, direct aortic cannulation, direct aortic cross clamping, as you can see here, and antegrade cardioplegia. This is a very simple technique, and also is much less expensive compared to Harport system and compared to robotic surgery. What about the operation? The operation is exactly the same, of course, with endoscopic instrumentation. If we have a posterior leaflet flail, we resect, then we suture with Gore-Tex cord, exactly in the same way that we do in sternotomy. So we change only the approach, we change the instrumentation, we have endoscope help us to do the operation. And as you can see here, for anterior leaflet prolapse, we insert the Gore-Tex cord on the anterior, on posterior papillary muscle, according to the leaflet, prolapsing leaflet. And this is very important because we can reproduce the same operation, and of course, we always put a complete ring. So from January 2009 to last year, we did 230 right mini thoracotomy for posterior leaflet, anterior leaflet, or both leaflets, and 20% need also tricuspid surgery. Mortality 0.4%, 100% we could repair the valve. Of course, we don't do mini thoracotomy in calcified mitral valve, calcified rheumatic valve. In this case, we don't do repair, and we don't do mini thoracotomy. Only to conversion to sternotomy, and this is our data. So I skip because lacking of time. Of course, following the criteria by Dr. Chen, you want to restore the triangular coaptation, and also the length of coaptation should be at least 7 millimeters. That is very important to have durability, long-term results. So restore triangular coaptation, and also a long coaptation length of both leaflets. So in conclusion, we may say that there is different advantages in minimal invasive surgery if we use the Smith operation, means the simplified operation, because you have percutaneous vein cannulation, antegrade perfusion, direct aortic cross clamping, 3 division, optimal or good exposure almost always, reduce complication rate and reproducibility. And of course, this surgery needs a good training, a long training, and also a previous experience through sternotomy. So high repair rate with less than 1% of mortality is a gold and new trend, we suppose, in this kind of surgery. Of course, this needs a big cooperation with the cardiologist. This is the end result of the operation. And the last conclusion is that different advantages is not only cosmetic, like in this nice picture by Italian painter Modigliani, but there is also less chest pains, quicker recovery, less bleeding. This is really minimally invasive. So minimally invasive can be a struggle, but also a pleasant navigation like in Mediterranean Sea. And I thank you very much for your attention. Mulțumesc pentru atenție.